Hello everyone and welcome to our Medimaps Project Theatre session. My name is Karen Hind and I am the Senior Director of Clinical Affairs, Research and Innovation at Medimaps Group. Two of my colleagues will also present today, and we have Dr. Lauren Nicola, who is a widely respected radiologist in the field and also CEO of Triad Radiology Associates, and Lauren will present on reimbursement for TBS. And we also have Professor Didier Hans, who will present towards the end of the session. Professor Hans is also the co-founder and CEO of Medimaps Group and will provide insights into the future advancements and future products from Medimaps team. So without further ado, we'll make a start. So I'll be starting the session with an overview of Trabecular Bone Score, TBS, and also providing an update on the latest IOF guidelines. Okay, so let's go right back to the definition of osteoporosis, and going back many decades, in fact, to the World Health Organization definition, which is defining osteoporosis as a systemic skeletal disease which is characterized by low bone mass and a microarchitectural deterioration of bone tissue, which then increases the susceptibility of bone to fracture. And with that, we can also consider the bone mass and bone microarchitecture as you would consider blood pressure, for example. You wouldn't just measure the diastolic blood pressure, you would also measure the systolic blood pressure. So the two go hand in hand. But let's keep that in mind and move to the next slide. So let's talk about the traditional approach, which has been around for many years now. So we all are very familiar with DEXA. Often in your clinic, it's your bread and butter. And we use DEXA to measure bone mineral density. And that addresses one aspect of the definition of osteoporosis according to the World Health Organization. Traditionally, this assessment of bone fragility is based on a BMD T-score, which is minus 2.5 or lower, fulfilling the densitometric criteria for osteoporosis. Now, while we know that the fracture risk increases as BMD decreases, we also know that more fractures will occur in patients in the normal and osteopenic zone. And in fact, 40 to 50% of osteoporotic fractures will occur in patients who don't meet the criteria for osteoporosis based on BMD T-score alone. So how can we improve fracture risk assessment? By elevating the standard of care. The answer is to apply the full World Health Organization definition of osteoporosis, which is applying both an assessment of low bone mass and microarchitectural deterioration. And we can do that all within the same DEXA scan. So we can acquire our measurement of BMD, and at the same time, we can also acquire a measure of bone microarchitecture by applying the method of Trabecular Bone Score, TBS. And this is, as I've mentioned, DEXA-derived. It's a validated measure which has been around many years now, over a decade, I believe. And it's based on a textural assessment of the bone of the image. Just like BMD, there are three categories of measurement. We have, for those patients who have a very poor microarchitecture, the TBS will be in the degraded category. And then we also have a partially degraded category and then a normal category of TBS. In the same way as with BMD, you will have your osteoporosis, osteopenia, and normal BMD. Now, with this, depending on the study, across many different primary and secondary osteoporosis categories, we know that we can identify around 30% more of osteopenic patients who are at risk of fracture who would not have been detected by BMD alone. And by that, we're actively addressing directly that osteoporosis treatment gap, which if you've seen the latest SCOPE paper, you will know is in the region of 71%. So that's 71% of patients who are not being picked up and at risk of fracture and are not receiving the treatment that they need. TBS is now well established as a standard of care across 60 countries. And over 3 million procedures are conducted using TBS every year. We are very proud here at Medimaps of our publication record, and we're pleased to say that we have a strong, robust clinical evidence base of over 1,000 publications. I believe that as of today, we're looking at 1,300 plus publications on TBS in terms of clinical validation in the field. We're also proud to share that TBS is included and supported in over 30 clinical guidelines across the world. So let's look at I would say a basic schematic of how we can see how TBS actually works in practice. So a good example is to consider two patients who may have the same BMD, but they may have different TBS. And if that's the case, then these patients will have a different risk of fracture. So here on the screen, you will see patient 1 and patient 2. Both of these patients have a similar bone density of the spine, indicating osteopenia. And then both of those patients also undergo a TBS assessment. Patient 1 has good bone microarchitecture, and patient 2 has poor bone microarchitecture, as indicated by the TBS assessment. Because of that, patient 2 is at a higher risk of fracture. A lot of this work the clinical validation was all started with the Manitoba cohort many years ago, which provided clinical validation of the fracture risk associated with the different levels of TBS. And with that, the bone fragility index. And you can see in the bone fragility index, we have the bone mineral density of the patient, and we also have the TBS of the patient taken into consideration. Now, if we were to consider patient 1's in the bone fragility index, patient 1 would fall into zone 4 risk of fracture, so the medium risk of fracture. Patient 2 would fall into the higher category of 7. So we've got patient who has of 6, patient who has osteopenic and degraded TBS, which then puts that patient at a high risk of bone fracture, at a similar risk to a patient who has osteoporosis. So we're really fine-tuning that assessment of bone fragility by considering both the bone mass and the microarchitecture. And if we were to integrate TBS into clinical practice by observing that elevated standard of care, you can see that this is seamlessly achieved alongside the BMD lumbar spine analysis. And with that, you will find an intuitive report which will provide both the FRAX adjusted for TBS and BMD T-score adjusted for TBS, and the useful bone fragility index, which you can also see there on the report. So now we can move on to the International Position Statement of the IOF. And this was an update on the clinical use of TBS in the management of osteoporosis, moving forward from the 2015 paper by Nicholas Harvey and colleagues, because a lot of evidence had accrued since then, which required an update of the evidence and the guidelines. Now, this was a paper which also included a symposium, and this took place after the ISCD position conference, which I believe was in March. And in particular, this IOF and SKO group were operating under the auspices of the World Health Organization Collaborating Center for Epidemiology on Musculoskeletal Health and Aging. And this paper was published in July last year. So the methodology for the development of this position statement was based on a robust systematic review. And in fact, there were 3 systematic reviews that contributed to this position statement. Within that review, 96 population or treatment studies were eligible following the strict criteria according to PRISMA. And from that, 22 expert statements were derived, and all of those statements were rated as strong via the grade criteria. And by the grade criteria, what that considers is the consistency of the evidence, so the critical mass of the evidence and the consistency, but also the strength of the evidence and application in clinical practice. There were 3 key reviews. The first was on primary osteoporosis. There was a review on secondary osteoporosis, and there was also a review conducted on the patient response to treatment in terms of the effect on TBS and whether or not TBS was a useful indicator for monitoring treatment. Here is the International Expert Working Group for the SKO and IOF, and Medimaps would just like to reach out and say thank you to each of these professionals for taking part and providing their time and providing such an in-depth position paper and really helping guide the clinical guidelines for TBS and integration into clinical practice. So big thanks to everybody who was involved in that. So if we were to look at this IOF statements on primary osteoporosis and fracture risk assessment, There were 5 statements in particular which confirmed that TBS is predictive of fragility fractures in postmenopausal women and men over the age of 50, that TBS is predictive of fragility fractures independent of BMD and of clinical risk factors, including FRAX. And this is important because if TBS is to add any value, it needs to be in addition to BMD and in addition to FRAX, and that it does. Thirdly, TBS adds predictive value when used in association with FRAX and BMD to adjust the probability of fracture. And BMD adjusted for TBS is an alternative solution when FRAX is not available. And finally, as I think you'll be aware from the previous presentation, the greatest utility of TBS is for those individuals who will lie close to the FRAX or BMD T-score intervention threshold. Now, the evidence base you will see on this slide, which demonstrates that TBS is predictive of fragility fractures independent of BMD and clinical risk factors. The evidence base included prospective cohort studies in both men and women, and the meta-analysis cohort, which was conducted by Eugene McCloskey in 2016, which provided the basis for the FRAX adjustment adjusted for TBS. So a strong evidence base. Now we can move on to secondary osteoporosis, and there were a number of statements which the IOF SKO have published on guiding the use of TBS in secondary osteoporosis. In particular, it was confirmed that TBS reductions are seen in most secondary osteoporosis-related diseases, that TBS predicts fracture risk in type 2 diabetes, independent of BMD and FRAX, and TBS predicts fracture risk in chronic kidney disease, independent of BMD, and in patients treated with glucocorticoids, in patients with rheumatological diseases, for example, rheumatoid arthritis. And it was also confirmed that TBS is relatively unaffected by spinal changes such as osteophytes. In addition, TBS adds value when used with BMD for monitoring the skeletal effects of aromatase inhibitors, and adds value also when used with BMD in monitoring the adverse skeletal effects of glucocorticoids. And finally, it was confirmed that there is evidence supporting the use of TBS for monitoring response to anti-osteoporosis therapy in both primary and secondary osteoporosis. And finally, we can look at the statements with regard to treatment. And there were 8 statements guiding the use of TBS for monitoring treatment. The first is that TBS continues to add value to FRAX in patients who have previously received anti-resorptive treatments. The second was that patients with low TBS who lie below but near the treatment threshold should be considered for an early assessment and lifestyle advice. So there's still some benefits there for those patients below that treatment threshold. TBS with BMD and FRAX probability contributes to stratifying anti-osteoporosis therapy according to fracture risk, directing those very high risk patients to the anabolic first approaches. TBS together with BMD can monitor individual response to long-term denosumab, and also for individual response to PTH and PTH analog treatments such as teriparatide and abaloparatide, and also useful for monitoring individual response to romosozumab. It was identified that a decrease in TBS more than LSC should prompt further clinical review, and TBS also contributes useful information for assessment of treatment response for patients receiving bone-forming agents or long-term denosumab. So here is the evidence base which those statements are derived from. You can see there's a number of cohort studies there, which are grouped into bisphosphonates, SERMs, MHT, denosumab, PTH, and romosozumab. And these studies range from 6 months to 120 months. And you can see with bisphosphonates, there are a number of studies which showed no change and was a preserved TBS as expected. But there was also a few studies which showed a significant increase in TBS versus baseline with bisphosphonates. Denosumab, there was greater success, PTH greater success, and also success with romosozumab in terms of seeing significant responses in TBS to these treatments. Secondary osteoporosis studies have reported that TBS is useful for monitoring the adverse effects associated with therapies such as aromatase inhibitors. But also secondary osteoporosis studies have showed that preservation or increases in TBS with certain osteoporosis medications. You see that TBS is useful in those cases too. So here we can wrap it up into one slide, really, which is a nice schematic, which you may have seen before if you've seen Didier or I presenting on TBS. But you can look at a population level, and this data is drawn from the published studies so far in terms of treatment effects on TBS and on BMD. And also at the individual level, we know we can apply an LSC just as you would do for BMD. You can apply LSC to TBS, and the average published LSC from 14 studies is 3.79%. So again, that's very, very similar to what you'd expect with BMD, but obviously you'd be encouraged to derive your own center-specific precision. We can see, as expected, we see patients would have an increase greater than LSC in response to the anabolic treatments in denosumab. Not so much with bisphosphonates. We wouldn't expect that. We'd expect to see no change given the treatment mechanisms of action. And that's always important to consider when you're looking at the BMD and you're looking at the TBS, which treatments are going to be most beneficial for your patients based on the knowledge of the mechanisms of action of that particular treatment and the overall skeletal profile of your patient. So finally, before I hand over to Lauren, we will look at how to actually integrate this integrate TBS into the daily clinical workflow. And this is also published in the IOF position statement last year. So do feel free to take that reference, please. But really, it's the same workflow as you would find for BMD. But you see that additional impact of having the TBS alongside BMD to provide an overall bone status and an understanding of the patient's global risk. And with that information, you can make a decision: should I treat? And then how should I treat? And then how long should I treat? With knowledge that not only are you considering the patient's bone density, but you're also considering their TBS as a measure of bone microarchitecture. And with that in mind, I'm very conscious of time, so I will hand over to Dr. Lauren Nicola, who will provide you an overview and very useful information on TBS reimbursement in the US. So over to you, Lauren.
Great. Thank you. So we heard a lot of great information from Karen about how important TBS is to improving the care that we provide for our patients. The other side of that is how can we make sure that this is a profitable service that we provide in our practices. So we're going to talk a little bit about the reimbursement structure for TBS specific to the US healthcare system. Next slide, please. Okay, so this is a busy slide with a lot of these cogs and wheels. It is intentionally busy to illustrate how complex the US healthcare reimbursement process is. I'm not going to get into the weeds of how all of these things work together, but the point here is that there's a very high bar in the US for getting a Category 1 CPT code for new healthcare services. It requires a lot of evidence that the service actually provides benefit to Medicare beneficiaries, a certain amount of utilization, and specifically just good evidence that this is going to be something that's going to move the needle for higher quality care. Next slide, please. So Medicare specifically in the US has several different ways to pay for innovation. So when a new healthcare service comes about that potentially can improve the quality of care, there's different routes that you can use to get that paid for. In the physician fee schedule, which is probably what most of us are most familiar with, that's through the creation of new CPT codes. Those CPT codes are assigned a relative value unit or an RVU, which is how Medicare will pay physicians and physician offices for providing that service. In the hospital world, there's the Hospital Outpatient Prospective Payment System, and Medicare uses something called an APC or an ambulatory payment classification to basically price and pay for services in the outpatient hospital setting. Inpatient, we're not going to talk about. There is a way for Medicare to pay for innovation, and of course, private payers generally follow Medicare's lead when it comes into which services to cover and more or less how much to pay for those services. We're really going to focus on the top two here, how Medicare pays for TBS in the physician fee schedule and in the hospital outpatient prospective payment system. Next slide, please. So when is TBS covered for patients? Well, it's performed alongside standard BMD exams like DEXA, so it adheres to the same coverage requirements as DEXA. And those, as you see here, so a woman who's been determined to qualify based on estrogen deficiency and clinical risk for osteoporosis, any individual with radiographic abnormalities indicative of osteoporosis or vertebral fracture or osteopenia. People that are receiving steroids, of course, greater than the 5 milligrams of prednisone greater per day for 3 months on average, anybody with hyperparathyroidism, and then a patient that's being treated for osteoporosis to monitor treatment response. So those are the common criteria for coverage. As you know, if you have any experience with coding, medical necessity is important. So it's important to know the history of your patients and to indicate that on any of your claims when you're submitting those. Next slide, please. So 4 new codes were created to cover TBS, and the code structure is a little bit unique, and it was designed specifically for TBS to account for the different ways that the service could be provided. It's a little bit unusual compared to DEXA and some of the other codes in the physician fee schedule. So the first code you see here, the 77089, is the global code. That is when the TBS is done in your office or in your hospital outpatient setting. The calculations are made all at the same site, and the physician read is covered under that service. So that's the whole package. And then the other 3 codes are if individual components of the service are provided in one place while others are done somewhere else. So the 090 is just the technical preparation and transmission of data. That one is if the calculation itself is performed elsewhere. The 091 is if the technical calculation is done by itself, so just the computation is done offsite. And then the 92 is the physician work component. So if the technical component is billed at one place, and then the physician fee schedule part, the 92, is the accounts for the physician work. So that's going to be important to remember. We're going to go through some examples of how that's used, practically speaking, but it is different. It's important to know that it's different than how DEXA is billed and how some more familiar codes in the fee schedules are billed. Next slide, please. So these are the specific payments in the 2024 fee schedules. So you can see the top line is that global code, the 089. And again, that's when everything's done by the same billing facility. That's the global code. That is corresponds to a 0.2 work RVU and a 0.98 non-facility PE RVU. The practice expense RVU is what some people call the technical component reimbursement. In 2024, based on the conversion factor, that is equivalent to $40.28 that the facility can bill, or the office can bill. Now, it's important to note this is almost identical to the DEXA payment. So for practices that are doing DEXA and TBS, it pretty much doubles your reimbursement for compared to doing DEXA alone. The 090 is a technical only component. Remember, that's when the technical preparation and transmission of data is performed elsewhere. And that's a lower payment, as you can see. The 91 is the technical component for the calculation only. So if you're a hospital facility who's doing the technical component, but a physician is reading it elsewhere, you would bill that code. It's $27.96 just to represent the technical part of that reimbursement. And then, as we said, the 92 is the physician work component. So if the physician is billing their services separately, they would bill that code. It's the 0.2 work RVU, which corresponds to a payment of $9.65 for the interpretation of that exam. Next slide, please. So that was for the physician fee schedule and the hospital outpatient payment system. So that's for hospital outpatient department. If you're an outpatient imaging center that's affiliated with a hospital or actually in a hospital, then you would use this fee schedule instead. The 89 doesn't apply because HOPS doesn't include a physician work component. The 90 and the 91, you can see there the corresponding payments in the HOPS. So $86.58. If there's a HOPD performing the technical part of the TBS, that would be billed by the facility. Next slide. Okay, so common misconception. I touched on this earlier. A lot of people are familiar with how DEXA is coded. On DEXA, there's a 77080 code. That's one single code for the global procedure. And if you're only billing the technical component, you use a TC modifier. If you're only billing the professional component, you use a 26 modifier. So in that case, the modifiers are what is used to distinguish between the professional and the technical components. Unlike DEXA, TBS has different codes to distinguish between the technical and the professional component. And again, that was done purposefully just in case There were some instances where maybe the TBS was done at one site, but it had to be sent off-site for the calculations themselves to be done. So the codes were constructed trying to make sure that there was fair reimbursement for every step of the process. So instead of the TC and 26 modifiers, TBS uses that global code, the 089, and then if it's not billed globally, you would bill either the technical component, the 91, the 90, plus the professional component for the physician read, the 92. Next slide. Okay, so what's the difference between the two technical components? The 90 is uncommonly used. Again, that is when the data is extracted from the modality on site, but then it's sent somewhere else for the actual calculation of the TBS to be done. In practice, at least in the current environment of how TBS is done, that is really uncommon to be done that way. So 99.9% of the time, you'll be billing the 91 if you're doing the technical component of the TBS. So if your DEXA machine has the TBS software incorporated into it, you will most likely be billing the 77091 code if you're not billing globally. Next slide, please. Okay, so a few coding do's and don'ts. This is just a picture of what the form looks like. Most of these are electronic now, but on the hospital outpatient prospective payment system side, again, this is for facilities and hospitals and outpatients that are affiliated with hospitals. The form looks like this. On the right-hand side, you'll see the physician fee schedule form. So that is used for if a physician owns an office and is billing the procedure as part of their office services, or if the physician is billing the work component separate from the technical component. Next slide, please. Okay, so here's an example. On the left, you see example A. The hospital outpatient department is using split billing. So the hospital is billing the technical component and the physician is billing their interpretation separately. So in that case, the facility is going to bill in the HOPS. They're going to bill the 91, the technical component, into the outpatient prospective payment system using that form or the electronic version of it. Separately, the physician who read the exam is going to bill the 77092 to account for the professional component and the interpretation in the physician fee schedule. Those will be billed separately. There's no modifier, no use of the 26 modifier like in DEXA. On the right, you see example B. So this is a example for an independent radiology center. So for example, a radiology practice that owns their own equipment, owns their own centers. In that case, they would bill for both the technical work and the physician interpretation. They'll bill that globally, and they would use the 77089, the global code, and that would be billed to the physician fee schedule. Next. Some coding don'ts here. So TBS does not replace DEXA. It's a little confusing because they have almost exactly the same value. So I think some people think that you bill one or the other. That's not the case. There is extra work and extra technical practice expense that comes with the TBS. So they're complementary. You bill the DEXA plus the TBS code separately. And of course, the combination of those procedures increases reimbursement for your practice. In fact, it doubles it. Unlike the DEXA code, which uses those 26 and TC modifiers to separate the technical and professional components, TBS has separate codes for each component. If you do accidentally amend a 26 or a TC modifier to your TBS codes, likely they'll be denied and sent back to you, and that can cause lots of headaches and potentially non-payment. So make sure you don't use those modifiers when you're billing TBS. And then do not bill the 89 or the 92 codes to the outpatient prospective payment system, because those are physician work codes. So the OPS does not have codes for physician work. So you would not bill either that global code, which includes the physician interpretation, or the code just for physician interpretation in the HOPS. Okay. And then I think this is one of my last slides. This is just an example in the physician fee schedule what the form looks like here. So at the top, you see the M810, which is the diagnosis code. Again, that's really important to meet medical necessity. Just because you have a code and just because you have a payment does not mean that you will get paid. You have to make sure that the patient meets medical necessity criteria. So that purple dot there is the diagnosis for age-related osteoporosis. You need that to get paid. And then on line 1, you can see the 80 code is listed. That's the code for DEXA. And then the next line, the 89, is that global code that we talked about for TBS. So that includes the technical component and the work component. So this is what it would look like if you're a radiology center that owns your own equipment, doing both the technical component and the physician interpretation. This is what your form would look like if you did a DEXA and a TBS. Next, please. Okay, and then finally, these are the states that we've had clients successfully billing Medicare for TBS. It is most of the states now. We've had a lot of success. Actually, it's uncommon for Medicare to deny these claims. They're very routinely reimbursed. So it has not been a big headache for most of our practices being able to bill the TBS and get reimbursement for Medicare. The same is true for most of the large commercial payers. We're still working on some of the smaller commercial payers, but a lot of success here, a lot of precedent for Medicare paying for this service. Next slide. That's it for reimbursement. I'm going to hand it back to Didier to finish this up here.
Thank you, Lauren. So I will take you to the next step. Not what we have developed so far, it's mostly what we currently developing or what we be developing anytime soon. But if I'm share here this slide, even though it's quite complex, you will see on the left side of the screen, you will see the patient journal on TBS inside ecosystems. So on the left side is a classical approach, what we call the reactive approach, where we have the patient being forced toward like a system based on the referring doctors with clinical risk factors, FRAX, and so on. But it's only concerned about 30% of the patient. That's where we have the TBS inside. So clearly, we will still going to improve the TBS inside osteo by having, for example, automatic spine segmentation just to improve the outcome and stuff like that. But the most important is you also have 70% of patients who fracture never been even referred to DXA, not even received treatment and so on. So the idea is to use what we call the opportunistic screening approach from X-ray, and that will be a mix of TBS and AI approach. That from a system, an X-ray that could be from spine, hip, pelvis, chest X-ray, that will flag your patient that should be sent to the DXA center and so on. Now, the second type of a pillar or third pillar, I will say, if you have a fracture and then you have to go to orthopedics or fracture liaison service and stuff like that, then we also have our product on TBS Insight, what we call TBS Insight Ortho, and I will dig into that. So next slide. I will just, in the next slide, cover briefly the different aspects of what I just mentioned from the patient journey. Next slide. So first of all, TBS 4.0. So a lot of people have been asking about the tissue thickness. We talk about BMI and so on. So first of all, it's important to realize BMI being used as a surrogate of tissue thickness for more than a decade, and all the value being quite extensively validated and worked for extremely well. Now, having said that, can we do better? The idea is just to try to improve the things. And one of the improvements that we felt, since we use the BMI as a surrogate of tissue thickness, we don't take completely through the BMI as the morphotype of the patient, whether it is more in the thigh or the belly and stuff like that. So with a newer version of TBS that will be most likely released by the end of this year, because we're going through the FDA process right now. So that will be through a TBS take into account the morphotype, meaning correcting directly for tissue thickness. So there is already a very good validation in-house, let's say, an external validation with more than 10 studies demonstrating that, first of all, that we improve the outcome of TBS, but also continuity with the previous version. Next slide. So from the next slides, one of the benefit of moving toward tissue thickness is not only just to take into account the morphotype, is also the fact that we can enlarge a solution to a different type of population, such as the pediatric, because the current software, TBS 3.x and below, cannot be used for children because the BMI will be a wrong indicator of the way to correct some soft tissue on those patients. So the idea of the new one will be to take that into account. And as you can see, we've already been working with Children's Hospital of Philadelphia and Cincinnati, And so first validation had been published a while ago, but the newest version have been used, and then there will be an update of that publication will be done anytime soon, demonstrating also the use of TBS in children. And the next step will be also just to do some fracture prediction with different cohort that have been already identified. So for the next slides, I'm talking about the A6R. I told you before the opportunistic screening. So we've been lucky enough just to gather quite a lot of data from around the world, totalizing about 100,000 scans. And just for the A6R from the spine to start with, we have almost 30,000. So what the A6R will tell you, it will from a simple X-ray, which could be the spine or pelvis, as long as you will identify automatically at least 2 lumbar vertebrae, either from the chest X-ray or pelvis or the full lumbar spine X-ray, obviously. So what we'll have will flag the patient which have been identified as a high fracture risk level by having a high bone fragility index, combining the minimum BMDT score for normal orthopedic osteoporotic from the spine and hip, and also the TBS. And then those patients will be characterized in the zone number 9, will be flagged and will be referred for further examination. And as of today, we've been presenting the result at the European Congress of Radiology and also at the World Congress on Osteoporosis last week. And the outcome was extremely well received, where we have a fairly good accuracy already with not the final product, obviously, but still having something around accuracy of 80%. So next slides. So what we'll do also, the idea is not just to stay with the spine, but go to more, which also can be a humerus, radius, hip, and so on. Well, everything will be detected automatically, but also we'll do some automatic vertebral fracture grading from an X-ray using also a similar type of algorithm. So from the next slides, I will not go on I6R, but I talk about the spine segmentation. So obviously, ICD been committed to improve the way we do analysis of the spine just to do that. Despite all the effort and all the courses, we still by far too often spine detection or edge detection around the spine that have been done properly or whatever. So the idea here was for us to develop an AI segmentation tool that will help just to do a more perfect edge detection than the one by default of the manufacturers. And where we compare here, we can see that between experts that been doing manually the edge detection versus AI, we have no significant difference between those two. While if you use an expert versus a per default manufacturer, you have a significant impact which exceed actually the least significant change. So which means that will be a real progress then, because we will help you by having these tools just to have an expert edge detection of the spine within few seconds, while otherwise it may take a bit more time. And we can see already that the impact that can have if you have the kappa components between the spine as by expert and also by AI, the kappa, which is a percentage agreement, is exceeding 90% actually. And if you have with per default, it will be less than 75%. So next slides. Obviously, a lot of people have been asking, what about the hip? So be patient. The hip is also around the corner, although we feel that the hip by TBS hip only will not be sufficient. So we'll come with a fine element, a hands fine element analysis, combining fine element analysis and also some TBS, which will improve also the bone strength from a mechanical standpoint from the AI, using a combination of AI, fine element analysis, and TBS. Next slide. And then to conclude, we'll also have the TBS on ortho, where we already have some nice publication that came out with a group of Neil Binkley in Wisconsin, but also with Anderson. We've been doing a pull-out study from the spine this time, and he has demonstrated that the pull-out study, that the correlation between the screw pull-out and the TBS had the highest correlation, even more compared to BMD or Hansfield unit from a CT scanner. scanners. So pretty much a lot of things in the pipe. And if we move to the next slide, and I will end on that, a lot of things being in the pipelines, a lot of new things come are just around the corner. In the next 6 months, a year to 2 years, you will most likely three or four different new products that be standing and aligned with the TBS itself, as you know, as of today. So thank you for your attention. And having said that, I think we're going to open for the next 20 minutes, 15 minutes, actually, almost. We will go through questions if you have any. So I will open the question session. So maybe there is 3 questions here that have been there. So maybe I will start with the one in between, and maybe Karen can answer this one. Is, will TBS eventually be able to be used in younger adult or even kids, teen, who have a high risk, such as chronic steroids?
Yes, absolutely. Good question, and a great clinical need. So as Didier explained, we now have the tissue thickness algorithm fully defined, fully validated. And the next step for us now is to progress that for pediatrics, an important population, because children fracture too, and we can do better there. So absolutely, yes, watch this space.
Mm-hmm. So there is a question from Alexandra that will be for you, Lauren. And can you comment, in a private practice which own the machine with TBS and rheumatoid rated, are we supposed to use the same code that you mentioned in your last example?
Yeah, so in the setting where the radiologist owns the office, they're doing the TBS, and then a separate physician group or rheumatologist is reading it. The radiology office would bill the technical component, and the rheumatologist office would bill the professional component, unless there's a global arrangement where the imaging center bills it and they've worked out something where they pay a percentage or something. We've seen some of those arrangements, but it would generally be billed separately by the rheumatologist.
Okay, the first question by Sherry. Our office had a Zoom meeting with Medimaps staff about 2 months ago and discussed finding about getting where we're getting on TBS compared to BMD. The staff of Medimaps told us to exclude vertebrae the same that's been excluded for DEXA. And the new ICD guidelines say you have to keep them all. Why is the difference in recommendations? So maybe I can start to answer, and maybe Karen, you can add on that. It's a slightly different philosophy. First of all, the FRAX adjustment have been developed mostly on 4 vertebrae, although the validation from the meta-analysis have been done on whatever was excluded by the BMD. So both approach will be quite correct. Now, having said that, why TBS is not impacted by osteophyte, meaning that potentially you could leave the spine, whilst the BMD you will have to exclude it. That might be quite different if you have vertebral fractures. So in case of vertebral fracture or metal artifact, then you want to exclude the vertebrae even for TBS. So we feel at Medimap that will be more conservative by just make it easier for you to exclude one, you exclude the others. Now, if you want to make the exercise to keep them all, a slightly different approach. And I can just, if you want, type the answer of what I feel that will be like an appropriate summary of that. I will type the answer into the chat so that you can see the difference between those two. We have another question from Alexandra Rodriguez. Maybe no, the rheumatologist office on the DEXA and they are reading. So that for you, Lauren, as a follow-up.
Yeah, so if the rheumatology office owns the equipment and is doing the reading, they would bill the 8.9 global code for both the technical and the professional component.
Yeah. So have no refugee, so we're good. So I have another question that have been just came quite often. Also, is the discrepancies between ICD and IOF HO guideline regarding reimbursement, not reimbursement, sorry, regarding monitoring. So obviously, ICD have been extremely conservative. and the conservative been mostly based on the bisphosphonate study, which is a major study that we have published with Bill Leslie around the Manitoba. And from that perspective, it's a bit misleading because clearly for bisphosphonate, both society, IUFHO under the WHO auspice agreed that the impact on bisphosphonates on TBS is not worth the monitoring, and I think both things, but they disagree because from the denosumab, for example, so Prolia or anabolic drugs, the effect is quite significant, and you see a significant number above the least significant change. Unfortunately, ICD didn't take that into account as they did in the past, but clearly with a TBS 4.0, that will just should square the two societies just to go forward. Now, having said that, IUFHO been digging further with more publications, and as you say, was more than 96 publications, but more than 96 since 2015, on top of what had been done before. So the total will be more than 200 publications. And at the end, the latest one really is from IUFHO. I don't have any question. Do you have any question that come regularly, Karen, that you may want to answer as an anticipation?
Yeah, I often get questions about the least significant change. And as I mentioned in my slide earlier, that the LSC is around about the same as you would expect for BMD, and you can apply that LSC in the same way. We have an average LSC of about 3.79%, but actually we encourage, as the ISD guidelines, that you acquire your own physician and LSC for your center. That's a common one that we get.
Yeah, well, another question that I've been seeing in the chat on another platform, where some people are saying or just saying that TBS doesn't add much, or one patient out of 100 and stuff like that. This is totally wrong. Because now many studies around the world, I say we have more than 3 million TB been calculated. So this is something that is absolutely wrong and misleading. Actually, if you have a normal patient through the practice, that will not be the case, even though the combination will add something. And one of the studies that we've been doing even on normal patients, where with Bill Leslie and actually Neil Binkley, we've been published in also International a while ago. They also demonstrated that you have about 10 or 11% of major osteotic fracture in a normal BMD zone. And even in a normal BMD zone, if you add the TBS in a normal BMD zone, you will recapture about half of those fractures, moving from 11-12% to only 4-5%, which is still a significant catch-up when it takes only a short period of time just to do that. So more question from Rodman. I'm in private practice and have prodigy, so I don't see the question. If the question is, can you use a TBS and a prodigy? The answer is yes. I have another question is, how do you calculate LSC for TBS? You will use the LSC. You can use the LSC calculator from ICD. That will be exactly the same thing. You will just calculate, you will just enter the TBS value instead of the BMD value, and the LSC calculator will do the same. Now, if you don't have the LSC calculator, you can do the normal precision, and the LSC will be 1.96 times root mean squared to the precision errors, and that will give you an outcome of that. So for you, maybe Karen, sometime I get DEXA with normal T-score, but TBS is degraded. Can you comment on that? I think I partly answered that with a fracture, but please.
Yes, of course. And that's the whole point of TBS. So TBS and BMD are not the same. They're measuring two different things. And this is why we don't expect to see the same results in both patients. It depends on the underlying cause of the fragility in the patient. Often we might see that in patients with secondary causes of osteoporosis. So for example, in rheumatology patients, etc. So don't be surprised if you do see discordant results between your TBS and your BMD. That's what we expect. They measure different things.
So sometime get number. So you answer this one. Another one that we have here. What is investment cost to get TBS? Well, I don't want to go into the costing because this is mostly a scientific session, and that will depend if you get it directly from Medimaps, from GE or for Logic. It depends if it's a bundle with the buying of a DEXA and so on. So this is quite, let's say, I'm not quite sure I want to get there, but if you want to drop a line to Karen or myself, we'll forward that to the salespeople that can get back to you on that. From Anne La Rochelle, any perspective of full data getting available for mail? Actually, not only corrected T-score.
So we have the BMD T-score adjusted indeed, and we do need more data on men for that adjustment. That's on our list. Always we have clinical validation ongoing all of the time, and really always looking to really strengthen that evidence base. So we're hoping for some studies in the near future with more men.
Okay.
For that particular outcome.
Yeah. So we have a question from James. TBS is based on L1, L2, L1, L4, but fairly often the vertebrae are omitted from the spine. I presume that the spine will need to be realized 2 times. There is a workaround. Well, two things. First of all, sometimes it's not L1, L4, which is better, actually. We have published several papers already now where sometimes even L1 to L3 will be better because L1 tend to be lower and just increase the most likely one to fracture anyway will be L1 as the junction between thoracic and the lumbar spine. And having said that, as a workout, usually the software is supposed to tell you to give you all the different combinations in additional material, so you can always use something like that. Another way to do it, to analyze twice, is once you have the BMD L1, L4 to start with, you can run the TBS. That will run the TBS on L1, L4, and then automatically you will have all the combinations as well. So there is kind of a way to work around. And hopefully in a newer version, we'll be able to do a bit like a G, where you can select the different type of combination directly from the screen and be able to print in a report the one you prefer. That will be the best one, but we haven't done that automatically yet. Hopefully it'll come around the corner. From the reimbursement, I know that sometimes private payers are pushing back, even though some other states, the same insurance on other states are just like reimbursing. So it looks like sometimes some discrepancies. Is that something which is common in the US or?
Yeah, it's common and it's regional as well. So it's something that we see amongst all codes, and no matter how established they are. The Medimaps team, I think, is great at working with practices and trying to get that payment covered. But I mean, overall, we've seen a lot of success, nearly 100% with Medicare and a lot of the other payers as well. So sometimes it's just a matter of persistence with some of the other commercial payers. Here's insurance denies saying that it was experimental. Yeah. And that's exactly what happens. Some of the commercial payers, especially the smaller ones, are saying that this is still experimental. And that's kind of, I think, where the Medimaps team comes in, because we have, of course, all this evidence that it's not experimental. It's actually quite useful and well established. So often we're able to convince those payers. And then again, it's regional, so you get kind of a domino effect of payers starting to cover it in one area, and then they'll all jump on board. So.
Yeah, I think if I may rebound on that one a bit further. At one point, I think your first slide, Lorraine, just demonstrate that the CMS process is extremely complex. And the complexity mean that CMS will never give a CPT code level 1 without a strong evidence, not even with that, be sure that it's been already used quite spreadly. And I heard sometimes that people, before the reimbursement, TBS was no existent. That's not possible. Otherwise, the CMS will not have gave the CPT code level 1. It will be potentially CPT code level 3, and clearly not level 1. So this is totally misleading and almost defamatory of some people, just like just spreading that around. Because actually there was a survey been done by the CMS folks or whatever, been working on that, just see how many people have been using. And at that time was already more than 400,000 to 600,000 people TBS calculated per year for the CMS. So I just want to reiterate that experimental, no, it cannot be at that stage, especially when you have more than 1,300 peer review papers and more than 30 guidelines around the world. If that's the case, then many technology will not even be on the market at all. And I hope that we were able to answer most of the question and concern that you may have through the presentation. So having said that, I wish you all a very nice Sunday and a good start of the week for tomorrow. Thank you all.
Thank you. Bye-bye.
Thank you. Thanks.